Hello, I'm Tony DeMaria, the editor of JACC, here with the highlights of our June 5th edition. And the first paper I'd like to tell you about is transcatheter aortic valve replacement in patients with severe mitral regurgitation. The question of whether or not we ought to subject patients to TAVI or Tavr, whatever the preferred pronunciation, if they have mitral regurgitation. So this particular study reports on some 450 patients undergoing Tavr who had mitral regurgitation of different grades from 2 centers in Canada. And what they found was that the patients who had severe mitral regurgitation had a higher 30-day mortality, but that after the initial 30 days, the survival in patients with moderate mitral regurgitation undergoing TAVI was essentially the same as those with no mitral regurg or mild mitral regurg. In addition, what they found was that about 50% of the patients with moderate or severe mitral regurgitation improved the degree of their regurgitation after the procedure. So although these patients who have severe mitral regurg would incur a slightly higher 30-day mortality, in fact, it does appear that in the long run, they not only do well from survival, but have improved levels of mitral regurg. Another study that's worth highlighting in JACC is a risk score to predict the long-term benefits from internal cardioverter defibrillators. Now, we all know that not every patient who receives an ICD benefits, and this is expensive therapy, so it would really be of value to be able to identify that subgroup of patients who would clearly benefit. And so the MADE-2 investigators had proposed and found a risk score that identified patients who might benefit. That risk score including age greater than 70, heart failure functional class of 3 or 4, elevated BUN, a QRS duration of greater than 120 milliseconds, or the presence of atrial fibrillation. Now, patients who had none of these risk factors were low risk. Intermediate risk was 1 to 2 factors, and 3 or more of these risk factors was high risk. And the important findings was that although in the early evaluation, patients in the low-risk category were not found to benefit from ICDs, in the long-term 8-year follow-up, in fact, these low-risk patients did receive a benefit. Now, the high-risk patients didn't benefit either acutely or in the long run, and so this should serve to identify a group of patients in whom the application of an ICD should be considered very, very strongly before it's applied. Now, the last study worth mentioning is a 2-hour accelerated diagnostic protocol for chest pain in the emergency room, a study that comes from New Zealand called the ADAPT trial. And in this study, they utilized 3 criteria to evaluate patients with chest pain. A pre-test probability score based upon the TIMI criteria, the presence or absence of an abnormal electrocardiogram, and troponin I values drawn at 0 and at 2 hours. And patients who were low risk were those who were identified as having a normal ECG, a 0 risk factor by the TIMI score, and normal troponins. And in fact, of all the patients they evaluated, 20% could be identified as low risk by these criteria. And the importance of this is that these patients could be discharged from the hospital with a sensitivity of recognizing abnormal events or predicting abnormal events of over 99%. So this is provocative. It clearly would be of major advantage if we could identify low-risk patients with chest pain who could be discharged from the emergency room in 2 hours. This is a protocol that will bear some confirmation, but one that offers a great deal of promise in that regard. For Inside JACC, I'm Tony DeMaria.